Today it's gonna be me. I'm gonna be alone, and I think we're gonna have a longer period for questions, and we can address any topic that you consider, any concern that you consider we haven't been able to deal with thoroughly. So let's start with the technical daily report. I'm gonna stand now. So here's we can look at the world situation with regards to the COVID epidemic, that is the COVID-19 disease epidemic, which is called by the new coronavirus SARS-CoV-2. As you can see here, this is the distribution for the cases during the last 24 hours. The European region is showing a decrease in the infection rate, which is good news for both Europe and the rest of the world. And the Americas is showing a slow increase, which is to be expected because these regions entered the epidemic at a later time than Europe and the Asian countries. 3/4 of the people have been infected with the virus during the past 14 days, which means these are the people who are actively contributing to the infection. In Mexico, we have accumulated so far 2,143 cases since we entered this epidemic on February the 27th, and unfortunately we've had 94 people who have deceased. And as we will continue to see in a little bit, these deaths are also, all of them are related to people who belong to vulnerable groups because of medical conditions that they had previously to being infected with this virus. Here we can look at the distribution per state within Mexico. We can see the highest number of infected cases concentrate around the Mexico Valley area and the state of Jalisco. Here we can, at this chart, we can look at the total number of infected confirmed cases, and of course Mexico City will continue to be the place with the highest number of cases, and this of course has to do with the population within Mexico City, which is the most populated region within the country. Here we can look at the incidence rate, the accumulated incidence rate, which takes into account the population per state. And we can see Mexico City is also leading the way in this chart. This is the number of infected cases per 100,000 inhabitants. Here we have the age distribution, which is the expected one. We were talking about yesterday that we have on average a younger population than Europe, and we've said that younger people tend to have less severe symptoms and less complications. At this slide, we can look at the distribution of inpatients versus outpatient, meaning people who the inpatients refers to people who showed symptoms severe enough so they had to be hospitalized. And the yellow bars are the distribution of these inpatients per age group. Next slide, please. This is a distribution by severity in the cases. As we can see, we have 76% of outpatients that show mild symptoms. We have 9% of hospitalized patients and a very tiny percent of intubated patients. As we said before, the The distribution per age group, when talking about the fatalities, the senior citizens are overrepresented in the fatality rate. And unfortunately, we have also people who are younger as compared to the fatalities presented in other countries that unfortunately lost their lives. And this is due to pre-existing medical conditions and overall poor nutrition characteristics within the Mexican population. Here we have the comorbidity rate that, as you all know, refers to the relation of the infection rate and the mortality with the pre-existing conditions. Now let's look at the lethality. Now Mexico exhibits a difference between as compared to other countries. In order to be able to compare how the disease is actually behaving within different states, we need a measurement which is called lethality. Lethality is the number of people who have unfortunately lost their lives with regard to or as compared to the group of people who became infected. And here they appear distributed per state within the Mexican territory. I would like to emphasize that while Mexico City has the highest number of fatalities, but it's not the it's not the highest incident, it's not the highest lethality rate. So, well, not necessarily Mexico City, but some states might have a higher number of fatalities, but they have a lower lethality rate when we take into account the relations that we have, the relation that we have explained. Now, this lethality rate will vary a lot because when we have a small number of cases, just one fatality can influence greatly the variation within this rate. So we will have to continue to observe the behavior of the disease in order to have more precise data in the future. Now, when we're talking about mortality, and I would like to call your attention to the difference between lethality and mortality. It is a technical term, but I think it is important to explain the difference. Lethality, as I have stated before, is the number of people who have died as a consequence of COVID divided by the number of people infected with COVID, and is a rate that can inform us against the risk related to the risk of dying of COVID-19 if you get infected. Now, the mortality is a measurement that talks to us about the overall probability of getting infected and dying. So, of course, we are not saying that we are not diminishing the role of the calling we've made to all the population to take proper measures and stay home, but the mortality is rather low. 0.74 per 100,000 inhabitants in Mexico, so it is a quite low number. At this moment, that we currently still are in phase 2, so we are not in phase 1 anymore, but we also haven't come to fully enter stage 3 or phase 3. So at this point in time, the risk of getting infected with the disease is relatively low. The probability is relatively low. And this is important to point out because what we are talking about right now is how probable it is for us to get infected right now. And the answer is it's not that probable. The probability is rather low. But it will get more probable, more likely as we develop into phase 3. And then the question is, well, if it's relatively low, why are we taking these isolation measures right now? Well, because I would like to reiterate what we are doing right now is going to have an effect, and that effect is going to be shown several weeks from now when we are actually in phase 3. So we're doing something today. Sometimes we do things today to have a result or an effect today. It is not the case with this pandemic. In this situation, we are doing things today, such as the isolation and safety distance campaigns and measures. We're taking these measures and we are doing things today in order to see the results when we reach phase 3, which is a couple of weeks away, approximately 2 or 3 weeks. So right now we have to continue to be very disciplined because we haven't entered the most difficult and most intense phase of the disease. So that tomorrow, when we have a more intense transmission rate, we can have a decrease in the number of infected cases, and we can have less fatalities, less infected patients, and we have enough capacity to provide proper treatment for all of them. Now, this is the list of diseases or health-related conditions that are related with fatalities, with deaths. Unfortunately, the people who lost their lives to COVID-19 had at least one or more of these conditions: hypertension, diabetes, obesity, kidney failure, etc. Fortunately, we haven't had so far any pregnant women who have lost their lives to COVID-19. This hasn't happened, although it is a possibility, and that's why it is very important for pregnant women to be especially careful and abide by all the measures that we have been implementing. Keep your distance, wash your hands regularly and properly. This index that we presented a few days ago is the positivity rate, and today we can go into further detail about this rate. The absolute number of people who are infected is a measurement that is directly observable in Mexico or in any other country in the world. We know, because of the way epidemiological vigilance works, that we can have other people who didn't seek for medical attention, they showed mild symptoms, and they didn't even realize that they had the disease. So these are contagions that are impossible to identify. We have said this before many times, and also with regard to other infectious diseases such as influenza. So we are not seeking to make an absolute statistic that covers every single one of the infected cases, and this doesn't happen anywhere in the world. Some people think that it is possible to identify every single patient, and that is not true. It is incorrect. We have compared this, for example, with the monitoring of the environment, and it's a similar thing. It's an analogy. One of the very useful measures to know if this epidemic is increasing and to what speed is increasing is this positivity percentage, which means out of all the people who show COVID symptoms, coughing, headache, throat ache, and other accessory symptoms like an impairment of the sense of smell, for example, all of these people are tested in a laboratory, sampling their respiratory secretions. These samples are analyzed in a laboratory, and they can either throw a positive or a negative result, specifically regarding COVID-19. Well, SARS-CoV-2. But in Mexico, we have a more advanced infrastructure that was developed during the influenza epidemic. And we had the capacities to analyze previously 13 different viruses, and now with this new virus, 14 different viruses. So it is possible that the person that is being analyzed will test negative for SARS-CoV-2, but will test positive for other viruses. Because we've had an important percentage of people who exhibit the same symptoms, but they do not test positive for SARS-CoV-2, but for other type of virus such as influenza. So the positivity percentages out of the people who are tested, how many of them test positive for SARS-CoV-2? And right now we are looking at a fairly low percentage, 2 out of 10, 2 out of 10 people who get tested and exhibit these symptoms actually test positive. In some other situations, they are positive for other viruses, and in some other cases, they are not positive for any of the viruses that we are able to test. So this positivity percentage is going to be being presented every day, and you will see that this percentage will show an increase in the upcoming weeks. We can also look at this, looking at the per state distribution. One of the advantages of this index is that we can evaluate the transmission within the territory. So for example, we can see that the Valley of Mexico area and meaning the Mexico City and the metropolitan area that encompasses the state of Mexico are showing a higher percentage of COVID, but also of influenza, as compared to other states that show smaller proportions of such viruses. So then we can see that the virus shows a patch-like distribution and is not necessarily homogeneously distributed along all states. Next slide is the accumulated infection rate curve, and we will continue to present this curve, making the comparison between the Mexican situation and the situation in other countries. It is important to notice that the maximum value that we present in this chart is 5,000. So a lot of these countries the curve would go up and up because they exceed the 5,000 cases. But we are interested in analyzing the Mexican situation. And the last slide, this is the same epidemic curve, but only the Mexican situation. We can see the increase in the infection rate per day. This curve has also an advantage, which is we can see how the virus has progressed. But it also has certain limitations because it doesn't present the recovered cases. It doesn't allow us to see the proportion of people who have already recovered from this disease. So far, we are not presenting the data of recovered patients because we are still working on preparing it properly and waiting for us to have a higher number of recovered patients. But during the upcoming weeks, we'll be presenting this information, and you'll see how the amount of recovered patients also increases. And the orange bars are the daily new confirmed cases. Thank you very much. Okay, let's begin. Yes. Natalia, Angeles, Blanca, and then you, and then you. Yeah, let's do it. Okay. You two, and then you two. You would like to keep your safe distance. You were talking about, Deputy Secretary, that Mexico City is not the entity with the highest lethality rate. Could you elaborate on this? Also, can a person be infected with both COVID and influenza? Yes, they can. It is rare, but it does happen. Now, could we potentially reach the situation Italy or the United States are at right now? I I think I think this is impossible to predict, but our hope is that as we abide by these measures, these mitigation measures that we are reiterating every day, stay at home, stay home, stay home. In this way, we will be able to control the epidemic. Please do not forget that this is a disease that there are no current medication, specific medication that can treat this disease. There is no vaccine. So the only control measure that we can apply is to have safety distance from others. It doesn't mean going outside. It doesn't only mean going out and keeping your distance. It means to the utmost of your capabilities staying home. A very useful measure is to reduce the number of people who are daily interacting in public and private spaces outside, supermarket, parks, streets in general, public transportations. For example, a lot of supermarkets have restricted, in the form of a recommendation, um, the presence of one person per family to do the grocery shopping. The recommendation that is being mm, presented by a lot of supermarkets is that if you're gonna go do some grocery shopping, only send one member of the family. Talking about the lethality, there are multiple explanations about this. For example, those areas in which we have a highest percentage of people who have chronic conditions, it could be that those areas have a higher lethality rate, a higher probability of dying. In the Mexican case, we do have age variations between different states, but they are small variations. In general, the south of Mexico is younger than the north part of Mexico, but the differences are not that prevalent. The But is there any state that has any particular high lethality rates? Well, yes, like we showed in the chart. Can we look at the chart again? It's a bar graph, blue with green. Next one. Yes. So look at it. These bars indicate the number of fatalities. For example, Durango. In Durango, unfortunately, 3 people have lost their lives. But if you compare it to the number of confirmed cases, 25% of them lost their life. But please do not overinterpret this graph because Durango has very few cases. So if we had one more fatality, then this rate would skyrocket. Or if we had prevented just one death, then it would decrease significantly. So we're still dealing with very early data, but we do want to present every piece of information from the very beginning so we can all together monitor this. Thank you. Good evening. And that 4.39 that we can look at the chart, and internationally the level of lethality is 5.5. So yes, thank you very much for pointing that out. And that is why I was emphasizing that we shouldn't interpret this data yet, because we have very few deaths comparatively yet. Of course, all of them very unfortunate, because each personal death is a tragedy in its own. But what would happen if we had more, or in the future when we unfortunately will have more deaths related to COVID? Then this data will begin to stabilize, and then we will have an average lethality that will vary between 4 or 5%, which is the actual international standard. Talking about the nurses and doctors that are being recruited, we were talking about 6,000 doctors and 12,000 nurses. Yesterday we were talking about these numbers. Are the people who belong to vulnerable populations included in these numbers? How many healthcare professionals have stopped going to work because they belong to a vulnerable group? About the protection equipment, there are some concerns expressed by different workers within the health sector, because they have access to different kinds of medical of health protection equipment. There is not a standard for the goggles, for the gloves, for things like this, so they don't know which one is the true standard. Also, we've noticed a variation in the outpatient proportion. Can you talk about that? Thank you very much. Very useful questions. Yesterday, the Secretary of Health being present, and some other colleagues and doctors, together we were talking about this need we have for recruiting more doctors and nurses. I would like to remind that as a country we had to deal with a rather disfavorable position for decades, which is that for many decades Mexico had less medical professionals working actively than it should. There is no an absolute number of how many workers we should have had, but if we make the comparison with other countries, members of the OCDE, we can see that we occupied some of the last positions when it came to the number of nurses and doctors who were actively working within the health sector. So when we had a situation such as this, which is completely unexpected and is a worldwide phenomenon, we have to work with what we have, and we have to make this system, this health system, work in spite of its limitations. And we have to remind everyone, and we have to remember that the Mexican population, 50% of the Mexican population, lives paycheck to paycheck, but meaning day by day. They don't have access to benefits, they don't have savings, so they depend on their daily work to be able to survive. So that is one of the important things to remember when we're talking about the health sector in our country. Now, when we established these extraordinary measures, when we declared the health emergency, national health emergency, we did establish that the preventive suspension of work activities would be very strict in the case of vulnerable groups such as senior citizens, pregnant women, and people affected by chronic diseases and high risk related medical conditions. But we also stated that the public interest personnel could voluntarily go to work, and this includes the health sector workers. If they want to go to work, no one will stop them either. So these measures are fulfilling two different roles, which is on one side protecting these vulnerable people, but also allowing these people who made who took an oath and made a commitment to the Mexican people and to the health and integrity of the Mexican people to be able to continue doing their labor. So what happened was that in several states, such as Yucatan and including Mexico City, there was a portion of the people, of the health sector workers, who said, I will stay home, I won't go to work. And they are protected by this disposition that we have established. So the hiring process that we are currently carrying out is precisely thought for in order to address this lack of personnel that we are currently experiencing. So it is very important to not lose sight of two things. One of them is the person who stopped going to work. That does not necessarily mean that they completely cease to work or they cease to engage in all of their work activities, because they could, for example, give their position temporarily to a younger person or to a person who is not part of a vulnerable group, and give this person the opportunity to participate, to save lives in an okay, let me illustrate this by an example. Let's say we have a doctor who is a specialist in intensive care and is over 60 years old and has a chronic disease. It would not be advisable for this person to be directly dealing with COVID infected patients. But we have reorganized in different institutions like the National Social Security Institute and different hospitals, the difference between COVID hospitals and non-COVID hospitals. So this person, this hypothetical doctor, we can reallocate them to move them from that COVID hospital to a non-COVID hospital, right? And he can be relegated in their functions in the COVID hospital by a person that doesn't belong to a vulnerable population. So we are carrying out this reorganization process, but I would like to make this public call to all of the colleagues that work within the health sector to identify this opportunity for themselves and be proactive about it the way we are in the medical profession. Instead of saying, I'll stay or I'll go, it's way more useful to see I could exchange positions with you, for example. And this is much more useful. And talking about the protection equipment, first of all, we're going to be having at the beginning of the next week a very large shipment of personal protection equipment that we have purchased from China, gloves, mask, and all of this equipment has been carefully selected by a technical team that for weeks has been analyzing all of the equipment that was going to be purchased We have carried out the purchase and is currently in the transportation stage and will be arriving really soon. Second thing, the immediate lack of equipment in many hospitals has to do with a misuse of such equipment. Please do remember, and I'm telling this, and I'm speaking to all of my colleagues within the health sector, we have published a set of guidelines for the use of medical protection equipment that has been designed by leading specialists in the fields, and these guidelines illustrate which professionals should wear what kind of equipment. So for example, the N95 masks, those ought to be used by the professionals that are going to be dealing directly with infected patients. So for example, if some professionals, because of a completely understandable but inadequate fear, if some of them want to use these kind of masks, the N95 mask, because of fear, but the situation they're working in does not merit them using it, then they're going to affect those professionals who actually need to wear these masks. So these guidelines are very precise when establishing who should wear what equipment. Let me give you an example that is not related to the health sector, but it will illustrate my point. Let's think about a person who does soldering, a solderer, an industrial work role. A solderer needs to work a special mask that has eye protection, specialized eye protection material to protect their eyes from the intense light that happens during the soldering process. A person who works within the same work area but is not directly engaging in the soldering does not need to wear such a mask. So I know this is not related to the health sector, but it's the same logic. Finally, the increase in inpatients, it's something that is going to continue to vary. We do not have absolute numbers of how that's going to happen, but we know it will happen in the developing weeks. Good evening, doctor. First, I would like to ask about this shipment that you mentioned. Is this large shipment that you talked about, can this guarantee that all of these demands by doctors all around the country are gonna end? Are they gonna be satisfied in their demands? And second question, talking about today's information, April the 5th, the infection rate, how is it looking? Has it increased? Has it decreased? Is it within a normal rate? What can you say about that? Well, regarding this topic, next week I'm gonna be presenting more absolute numbers, and I haven't wanted to give you specific information so far because we are still monitoring the data and we are still coming up with more specialized numbers, but the Sentinel monitoring protocol started 1 week ago, and it requires to gather information from, in general information from all of the 26,000 medical units within the country. Now, all this information is gathered during the period of a week, and then is processed, and then we can present it to the public. That is the way this model works. So next week we will have these projections and information to present to you. I think it is an early stage to look at the effects of these mitigation measures, because the incubation period of this disease is 7 days, and the proper disease period is 10 to 14 days. So we need at least 15 days from the beginning of the mitigation measures to actually start seeing the results. And about the large shipment, do you think that will meet the demands from the medical professionals? Well, I don't I don't think necessarily the complaints or the demands should stop. I think it's very important for all medical professionals to be able to express any concern they have. All of your concerns will be heard, will be taken into account. You are a key component of the strategy for fighting this pandemic. This is an extremely difficult situation and it will continue to be difficult and will get worse. So, you, colleagues, all of you, nurses, doctors, chemists, therapists, all of you who work in the health sector are going to be under a lot of stress dealing with a very complex situation, but it's going to be thank you to you all that we will able to pull through and move forward. You're going to be the protagonists in the phase 3. So it is very, very important that you express any concern that you have, and we will listen to it, and we will do our best to address all of your concerns and demands. And it's very important that everyone knows that the difficulty in having sufficient equipment has to do with the fact that this is a global phenomenon. For example, the United States is right now dealing with a way greater difficulty in searching this and finding this medical equipment because originally a lot of equipment was sold to other regions, to Europe, and now they're having difficulty in finding enough equipment for dealing with this pandemic. So we will be taking and are taking the proper measures to guarantee that all of our health professionals are taken care of. Thank you very much, Doctor. I have several questions. First of all, what is the situation of the undergrad medical interns? Because we've heard some of them don't have enough materials and also they've been suffering discrimination. And this has happened in Mexico City, Yucatan, Coahuila, and other states. And some of them has said that they are not being provided with the material because they are being explicitly denied the right to have this material. Some of the local medical authorities have expressed their own views or dealt with the situation in their unique manner. Some of them have abided by the measures implemented by the government, but some of them haven't. So, what is this phenomenon? What does this mean? Is there a lack of coordination between the federal level and the local level within the health authorities? A few days ago, Dr. Reyes Teran told us that they hadn't reached a final decision when talking about the interns. Have you reached the final decision now? And if you have, what are the characteristics of how you're going to be dealing with interns? And I ask you this because we haven't entered phase 3, but what's going to happen when we enter phase 3? What's going to happen with the interns? Another question is related to the transfer factor developed by the National Polytechnic Institute. You said that the government is not discarding a protocol of such nature for dealing with this epidemic, but the director of this protocol has stated that they only waiting for the federal government's approval to be able to start trials. And last question. Last Wednesday, a local news media was saying that the virus is terrorizing everyone that is inside the hospital La Raza. And we've seen that the tests have been taking several days in some cases. So could you talk about this as well? But for me, the most important topic that I would like you to talk about is the situation of the interns in the hospitals. All of us, we are at risk. Also, all of our families. But of course, the health sector professionals, the health professionals, they deserve special recognition because they're playing a major role, and they have an increased risk because they are being exposed in a greater manner to the infected people. So these interns that you're talking about, they are currently being trained. They are not hired formally. So they are working under a scholarship. So the legal responsibilities and the administrative responsibilities that are attributed to these institutions who are training these interns are very different to those of professionals that are actually hired. Now let's remember that in 1997 the medical system in Mexico was decentralized. So when we're talking about what is the Ministry of Health doing, remember that we're talking about several health authorities. We have the Federal Ministry of Health, but we also have 32 local health systems and health authorities that have responsibilities on different domains, including the hiring processes of different professionals. So when you talk about a lack of cooperation or coordination, I think you're talking about a diversity that exists in our country, because the governor of each state is the health authority in that state. So it is part of their area of responsibility, and because of this, there are decisions that are gonna be taken exclusively by them. Each state is free and sovereign, so they are in a situation to make their own decisions. And talking about the protocol developed by the National Polytechnic Institute, each institution should have an ethics committee. All, all academic institutions and technical institutions have one. So that is why that is I'm sure they have a research ethics committee that has a biosecurity commission, an ethics commission, a research commission, and they are the ones that should be putting forward the proposals regarding any new proposed research. Talking about what you said about the Hospital La Raza, I don't know quite I don't quite know what you're referring to, but I can tell you that the La Raza Hospital was one of the first sites in which we established an epidemiological vigilance laboratory, and they have all the infrastructure necessary to run the test. And the test takes 6 hours to be processed, more or less, and the overall process maybe takes 24 hours, 26. Okay, next to last question. Yeah. Okay, Deputy Secretary, we are 6 people short of reaching 100 deaths, and we are in phase 2. What is the explanation for this? Is it because of the chronic diseases that a big percentage of the population has? Is this why the deaths have doubled or tripled? Can you explain these 94 deaths? We have had reports of the death of a policeman who became infected at the Vive Latino concert. Is that true? And can you comment on the shipment that you were talking about? How many pieces are we talking about? When are they arriving? And when are they going to be distributed? And there is also a question that I'm being constantly asked, which is what protocol is going to be implemented for the people with disability of some kind. I don't have the specific numbers regarding the shipment. It is precisely being loaded right now in China. And how long it's gonna take, well, it really depends on the flying conditions. But next week the shipment will be arriving, and we will have enough equipment to deal with the current situation so far. How many specifically, how many units, we still don't have a final number. Regarding this policeman, citizen that you're talking about, I would like you to share more information about this specific case to know what was the date in which he became infected. We know the Vive Latino happened the 14 and 15 of February, so it would be interesting to know if this person showed symptoms at the end of the month and then became hospitalized. And it would be probable that he got infected during that weekend. But we would have to have more information in order to determine whether he actually got infected at the concert or not. We would have to have more specific information regarding his activities. And the question about the deaths, unfortunately, Mexico has an advantage, which is the people's youth, but has a huge disadvantage, which is the high incidence of chronic diseases related to poor nutrition. And we've talked about how this poor nutrition situation is related to the current supply of healthy foods within our country, and the new initiative of the proper labeling of foods is precisely related to this problem that we have. So this situation within our population is something that is gonna be a disadvantage for us when dealing with the virus. So does that mean that when we reach phase 3 we're gonna have more fatalities? We've had said once and again and again and again and again that when we say stay home, stay home, stay home, stay home, not tomorrow, but today, stay home today, because that's how we can decrease the amount of cases and the amount of deaths. We're dealing with a disease that has no specific treatment, that has no vaccine, and the only way we have to decrease the infection rate and to decrease to the utmost of our capabilities the number of fatalities and the number of infected cases is to stay home and abide by the proper social distancing measures. So we have an opportunity today. Please, if you're listening to me right now, think of a loved one. Think of yourself. Think of a stranger. Think of someone who could become infected if you don't do your fair share, if you don't do enough to prevent this epidemic from spreading even more. So, if you wash your hands constantly, if you stay home, if you protect yourself with your elbow when you sneeze, if you, in case of exhibiting any symptoms, isolate yourself at home, and in that case, wear your face mask, to the degree that you do all of these things, that's the degree to which we will be able to control this epidemic and reduce the number of fatalities and infected cases. We've said that we estimate that we're gonna reach our highest number of infected cases during the month of May. And talking about the inclusion related topic, those people who have some sort of disability need specific cares and special care. So the critical point here is that if a person with some sort of disability becomes infected for some reason, that doesn't mean that we should not be there for them within their family, within their community. There are specific mechanisms that are the same that work for any other population to lower the risk while still providing support for this person who needs it. For example, in terms of mobility, if a person needs someone to assist them to transport themselves, we need the members of their family and of their community to help with that. If one of these if one of these people with disability get infected, first of all, they have a right, just like anyone else, to getting proper medical attention. But if it is established that they show mild symptoms, they should be staying at home, wearing a mask, and the people assisting them should be washing their hands regularly. This is it for today. Our time is up. We will continue tomorrow. Thank you very much.